Good evening, friends. Today's topic of discussion is polycystic ovarian syndrome. Now, if I ask you what is it that you already know about PCOS, there are certain things we already know, like there is cycle irregularities. We know most of the things that are present in PCOS, but we don't know how they are connected. There's amenorrhea, as we all know. There's an ovulation, or there can be oligo-ovulation. Then there is hirsutism, as you call it. A better word is hyperandrogenism, because other features are there too. Then what else is there? There is features associated with metabolic syndrome, like deranged glucose tolerance. Alright, there is what? Incidences of increased BP associated. There is dyslipidemia associated. And there is one more thing which is called acanthosis nigricans. Indicates hyperandrogenism and insulin resistance as well. How do you diagnose the condition? Do you know the name of the criteria which is used? Very famous. Rotterdam's criteria. Now, problems that are associated here. So finally, what are the problems that your female patient will present with? An amenorrhea of varied lengths of time. An ovulation. This will cause infertility. Then hirsutism. And then you have to be concerned about these things. She doesn't know about these things. This will come out of diagnosis, the test that you do. So these problems are important to keep in your mind when you're treating such a patient. Now coming to the pathophysiology. Pathophysiology of PCOS is very important. This is how you're going to know what all symptoms are there, how to diagnose, and what are the treatment methods that can be done. What are the treatment options that are available? So 50 to 75% of these women have insulin resistance. If there's insulin resistance, blood glucose will rise. Blood glucose levels will rise, alright. If blood glucose is rising, in return, insulin will rise. Insulin has twofold action. One is on the liver, the other is on the ovary. On the ovary, it increases androgen secretion. So ovary will produce more androgens now under the influence of insulin. And on the liver, insulin decreases sex hormone binding globulin. If this is decreasing, what increases is free testosterone. And if free testosterone increases, it in turn disrupts glucose metabolism and causes more insulin resistance. Androgens also act on the liver to decrease sex hormone binding globulin. So this is one cycle that is operated. The other important cycle is associated with androgens. So at one end of the pathophysiology, you have insulin resistance, and at the other end is increased androgens. Now this is responsible for most of the manifestations of PCOS. What happens when androgens increases in the body? It acts at three levels. The HP axis, hypothalamo-pituitary, or even the ovary axis. HPO axis, it disrupts the axis completely. Normally in a cycle, if you remember the previous slide which I had said, there is increase in FSH, there is increase in estrogen, FSH falls because of negative feedback and then again rises, resulting in rise in estrogen. This rise in estrogen gives positive feedback to LH, which rises, and finally there is ovulation on day 14. This is completely disrupted in a PCO cycle. What you have is increased LH as compared to FSH. So FSH is low, LH is high. If you remember what I had said in the previous lecture I had taken on menstrual cycle, I said that LH is responsible for production of androgens in the ovary. Alright. And this is converted to estradiol only in the presence of FSH. What is happening in a PCO cycle is you have LH increased amount of LH and decreased FSH. So the end product finally is androgens because sufficient FSH is not there to convert it to estrogen. Now for ovulation to take place, you require, if you remember the antral follicle, there is this antrum. You require excess of estrogen in the antrum to cause or to help in ovulation. When the microenvironment changes to excess of androgens, and ovulation occurs. So by disrupting the HP axis, it is disrupting the level of hormones, the sex steroids, and it is causing an ovulation. At the level of ovary, one, it causes an ovulation. Why does it cause an ovulation? We have seen because of the disrupted HP axis and because of increased ovarian androgens. Now from an ovulation, what do you have? You have more number of atretic follicles. Now in a normal cycle, you had one of these follicles growing to the large Graafian follicle and then ovulating and then changing to corpus luteum. This is not operative. No corpus luteum forms, no dominant follicle forms, no ovulation takes place. So one thing is there's no progesterone. That's a different thing. Now here what happens because of anovulation is you have all the follicles finally will secrete androgens for some time and then will finally undergo atresia. More atretic follicles, more stroma. So there is more substance to produce androgens. So in the end, there's a cascade, there's a cycle which again itself increases the androgen production in the ovary. In the periphery, what happens is that these androgens are converted to estrone, E1, which is a weaker form of estrogen. So E1 to E2 ratio increases in PCOS. Now this androgen excess and disruption of all these sex steroids and gonadotropin levels is responsible for most of the manifestations of PCOS. Alright, this androgen is responsible for anovulation causing infertility. This is responsible for hirsutism. This is responsible for, again, increased insulin resistance and the metabolic syndrome. So this is at the center of your pathophysiology. Now coming to the diagnosis. Diagnosis has 3 parts. 2 out of these 3 should be present. One is hyperandrogenism, which can be clinical or biochemical. That we will see later, which is important, which is to be done. Then anovulation, oligoovulation. How do you know that a particular cycle is anovulatory? In a normal cycle, you have dysmenorrhea, you have PMS, you have premenstrual molemina when she is ovulating. Usually these things are absent when she is not ovulating. And then PCO on USG. Polycystic ovaries is defined as more than or equal to 12 follicles and at least one ovary of the size of 2 to 9 mm. Or the ovarian volume is more than equal to 10 cubic centimeters. Okay. 2 out of these 3 conditions in the absence of any other cause of androgen excess. So you have to exclude other causes of increased androgens in the body. Now considering each of these points individually, we have talked about anovulation, we have talked about PCO, we are left to talk about hyperandrogenism. Hyperandrogenism, clinical hyperandrogenism में क्या क्या होता है? You have acne, well known, hirsutism, very well known, and you can have alopecia. The other symptoms like hoarseness of voice, like features of virilization, are not very common in PCO. How do you grade hirsutism? There's a scoring called, if you remember, there's a scoring called Ferriman-Galway. This is given nicely in Harrison's in our chapter. Now Ferriman-Galway scoring, normal is this, it scores the hair growth all over the body. Normal is less than 3 in a normal female. If it is 6 to 8, it is indicative of, more than 6 to 8 is indicative of hirsutism. Alright, now let us see what are the normal androgens present and what levels they are present in a normal female. This is not a PCO female I'm talking about. I'm talking about a normal female. In decreasing order of serum concentration, the maximum amount present in a normal female is DHEAS in contrast to men. They have the maximum amount of testosterone. So here, because adrenals is the main source of androgens, DHEAS is the major androgen they have. The source of DHEAS is adrenals. The main source is adrenals. Then there's DHEA. If you don't know if you didn't get the full form, it is dihydroepiandrostenedione. And then there is androstenedione. Then there's testosterone. Testosterone, this 25A, O, and 50P means that 25% is produced in the adrenals, 25% in the ovaries, and 50% in the periphery. Dihydrotestosterone, the most potent form which is responsible for hair growth, is the 5-alpha reduced form. So there's an enzyme called 5-alpha reductase which converts testosterone to dihydrotestosterone. Alright, so let us compare. There's an MCQ asked on this, that's why I'm giving you this table on the levels of testosterone in men and women. The percentage is bound to sex hormone binding globulin, bound to albumin, and the percent that is free. 78% in men is bound to sex hormone binding globulin, 19% to albumin, and 3% is free. Here it is 80% to sex hormone binding globulin, 19% the same to albumin, and 1% is free. So there's this difference of 2% of free testosterone. The levels, if you ask me, in females is 20 to 80 Ng per ml, and it is almost 10 times in men, 280 to 1100 Ng. This is nanograms per ml. Alright, so if in a female you have more than 150 Ng per ml, it is a point of concern. Is that visible? It's more than 150. Now, when are we going to do these androgen levels in a female? As I said, she is either going to have acne, hirsutism, or alopecia to call her hyperandrogenic. Now, if she has all these things, there's no need to do a testosterone level or a DHEA level or any other levels in her, because she's already having hirsutism. Even if the testosterone levels are normal, you have to treat this. So the biochemical tests are not very important. Now, when to do these tests? When there's rapid rise, or when there's rapidly progressing acne, hirsutism, alopecia growing over a short period of time. Normally in a PCOS cycle, you will have a female who will not remember when the acne or the hirsutism started. She'll say when she attained menarche, these problems started to set in, and they have been increasing since the time. Whenever there's rapid progression, sudden appearance, and it is considerable, it's not mild as seen in PCO, then you do these testosterone levels. And if you have to do a androgen level for PCO, you will do the testosterone levels, because testosterone is produced from ovaries, and ovaries is the organ producing androgens in PCO. So if you are asked which androgen level you will do in PCO, you're going to do testosterone. This is the most sensitive in PCO. Otherwise, there is no need to do any androgen levels unless there is rapid progression, sudden appearance, and considerable in amount. Amount is not a proper word. I hope you have understood what I am trying to say. This we have discussed, clinical versus biochemical. When to do androgens we have discussed, and which one to do. If you are suspecting an adrenal source, do DHEAS. If you are suspecting an ovarian source, do testosterone. What other tests? Just 1 minute I'll take to discuss what other tests you will do if there's androgen excess. Apart from the testosterone levels, do 17-hydroxyprogesterone to rule out non-classical form of CAH. Also do 24-hour urine cortisol to rule out Cushing's. Now this Cushing syndrome or Cushing disease is very rare. So unless you have features, Cushingoid features, don't do this test. These are the rare conditions, and the other is tumors. That you will get to know from the levels. These are the rare conditions you would want to rule out if there is sudden and rapidly progressive rise in features of androgenism. Cycle and PCO, I think we have discussed this here when I said there's no ovulation. So the deficient hormone here is progesterone. What happens to the endometrium? Because there is only estrogen in the cycle, there is no progesterone. Estrogen is responsible for proliferation of endometrium. So you have an endometrium which goes on proliferating continuously till a stage is reached when it becomes so friable that whatever amount of estrogen you have in the body, it is not going to sustain and it is going to break. This kind of bleeding is called breakthrough bleeding. This implies that although the hormone is present in sufficient levels in the body, the endometrium is so thick, so proliferative that it has become friable and it is going to break. Now this shedding is not up to the basal layer. when in normal menses periods occur, the shedding is up to the basal layer from where endometrium will regenerate. Now here what is happening is a part is shedding and there's no regeneration. So usually the bleeding in PCO is heavy. The other kind of bleeding that occurs is withdrawal bleeding. Why should there be a withdrawal? Normally you have a cycle where estrogen is at its high baseline level. This is because of the ovary which has multiple cysts and which are producing androgens and some amount of estradiol. So this is basically at a particular baseline level throughout the cycle. Sometimes what happens at a particular point, a particular time, all of these undergo atresia. Coincidentally, sometimes all of them will atrophy at the same time. So the other day, one day you have multiple follicles producing estrogen and the other day you have an ovary there where there's no polycyst, multiple cysts, multiple follicles are not there, and so the source of estrogen has decreased for a time being, after which some will again regenerate, start growing, and again you will have polycystic ovaries. For this period of time there is a brief fall in estrogen resulting in estrogen withdrawal, which can also be responsible for bleeding. So that is what a cycle in PCO looks like. You have an amenorrhea of a long time followed by bleeding, which is usually heavy, might not be heavy all the time. Plus the other thing on endometrium is, since there is continuous proliferation, there is a risk of endometrial hyperplasia and there is a risk of endometrial carcinomas in patients with prolonged anovulation or chronic anovulation. She comes with a history of irregular cycles, infertility for a long time, for 10 to 15 years since she had menarche. You are interested in ruling out endometrial hyperplasia and endometrial cancers in these patients because these things need treatment. Now before you start to treat a female, you need to know what problems have to be taken care of. A 17-year-old female with PCO will be mainly concerned about her missed periods. She doesn't want to do a UPT every time she misses a period. The other problem this girl is facing is hirsutism and acne. She wants to get rid of these two problems. And a 25-year-old married female, she is mainly concerned about her infertility. So what do we do? What was deficient? Progesterone. How was your cycling? A baseline level of estrogen. And your endometrium goes on proliferating. What I do is I mimic the physiologic cycle. This is day 0, this is day 12, 14 and 28. From 12 to 14, I start giving her progesterones. I give it for another 12 to 14 days and I withhold it for 7 days. In this period, she is going to have progesterone withdrawal bleeding. Alright, so I have regulated her cycle. I gave it till this time, 14 days, from 12 days, and then I gave her a 7-day drug-free period when she's going to bleed because of withdrawal, progesterone withdrawal. Now, if you give progesterone to this endometrium which was continuously proliferating, it undergoes secretory changes, gets glands, gets stabilized, the proliferation is settled to some extent, and then when you withdraw progesterone, this sheds. So you have a period of bleeding. Again, I'll ask her to come on day 12th to 14th. I'll start progesterone. This is drug-free period. I'll ask her to start progesterone from day 12 to day 14. I'll give this drug. Then 7-day drug-free period, she bleeds. So this is how you can control her cycle. Alright, so one logical thing is to give progesterone from day 12 for 14 days and then give a drug-free period. What is the problem with this is that it is difficult to advise. You have to tell her to remember the day 12 of a cycle every time, the cycle which you have started. And every time she has to have this 7 days gap and then again a 10 days gap and then started on day 12. So it is difficult for a patient to monitor her own cycle and to start it from the proper day. And the other thing is that it is not taking care of hirsutism and acne. So what we do in them is we give E plus P. If you remember the previous slide that I discussed, I had told you one important function of E plus P is feedback. to the hypothalamus and the pituitary. If you give estrogen and progesterone in this cycle, I give her estrogen and progesterone from day 0 to day 21, and then I give her a 7-day drug-free period. What happens is this high level of estrogen and progesterone is going to give feedback to FSH and LH, which are going to come down. Okay? So the disruption in HP axis which was brought about by androgens has been brought under control to some extent by E plus P. They have simply decreased the secretion and release of FSH and LH. So the disruption, the disorder which was created comes down. LH comes down, androgen production comes down, hirsutism and acne, the symptoms of hyperandrogenism, will be relieved to some extent. So these are the two logical treatments you can do in a case of PCO. The other important thing is related to insulin resistance, lifestyle modification. They say a weight reduction of even 2 to 5% can improve the cycles in a PCO female. Second we talked about was progesterone, then estrogen plus progesterone. Now there's a female who is either sensitive to estrogen plus progesterone or doesn't want to take estrogen plus progesterone and is bothered only by her hirsutism. So what we can do is we give them anti-androgens. Hirsutism and acne. She's only bothered about these conditions. She's not either having irregular cycles or she's not bothered with her irregular cycles. So anti-androgens can be given, which are spironolactone, cyproterone, or flutamide. And then there's a drug called finasteride. This finasteride, that's a correct spelling? Yeah. This is 5-alpha reductase inhibitor. If you remember, we had discussed this enzyme. It converts testosterone to the most potent form, dihydrotestosterone, which is responsible for hair growth and acne. Alright, now considering this 25-year-old female who has infertility. So how do you treat infertility in these women? What is the problem? And ovulation. What I'll give? Ovulation inducing drugs. The most common, clomiphene citrate. If she doesn't respond to this, then what do you do? You give metformin. We didn't talk about metformin in the treatment. There's one more treatment you can give, metformin. What does it do? You know all this? Insulin sensitivity. It increases insulin sensitivity. So your pathophysiology is reversed to some extent. Alright. Now, coming to ovulation induction failed with clomiphene citrate. So I can try metformin in her. Metformin plus CC. Or I can give her a ocipal cycle of 3 to 6 months and then give her CC in the next ocipal free cycle. If still any of this is not acting, there's one more thing you can add, dexamethasone. If all these things don't act, then what we do is we give gonadotropins in them. Or the other option available is what? Ovarian drilling. Ovarian drilling kya karega? What you do is in the ovary you make multiple punctures. You destroy some amount of stroma. So this excess stroma, the large size of ovary was responsible for increased androgens. So if you decrease the size of ovary for a time, the androgen in the cycle decreases for some time, and then the probability that the cycle will ovulate, that she will ovulate in this cycle, increases. So this is how you treat the direct manifestations of PCO. There are certain other associated health concerns which we have already discussed in bits and parts, which we have to take care in a patient of PCOS. Now this young female of 17 to 25 years does not know that she is at a high risk of diabetes mellitus. So you are going to do her GTT. Alright. You are going to do her endometrial biopsy if she has been chronically anovulating. You are going to measure her BP. You're going to do her lipid profile. This is for your interest, for health concerns of the patient. She is at increased risk of all these things. Alright, so this is all about PCO that I had to talk. Now your homework is go and solve MCQs of this chapter, and if you have any doubts, please post in the comments. And also tell me which is the other topic you want me to discuss, anything you want to understand, because it gets easier to learn things when you understand them. All right, thank you very much.